Hello students, we are moving on with our discussion in medical lecture series. We are going to discuss pathology, and in pathology we are going to discuss neoplasia. Neoplasia is very important as far as medicine is concerned because you will encounter patient in medical practice with neoplasia. So it's very important to understand neoplasia in detail. My name is Dr. Machera, and this is a lecture series dedicated to clinical officers students. Don't forget to subscribe and have a notification turned on so that you can be updated with the upcoming lectures. I used to update lectures daily, so it's better to subscribe and have a notification turned on. In this discussion, we have the following outlines, which I call learning objectives. We have to pass through introduction of neoplasia. So it's very important to be introduced to neoplasia. After that, we have to pass through definition of important terms in neoplasia. Then we have to pass through nomenclature. Nomenclature means naming. We have to see how neoplasia are named. After that, we have to see characteristic of benign and the malignant neoplasia tumors. This is just to tell us that neoplasia are grouped into benign and malignant. After that, we have to pass through grading or staging, grading and staging of these tumors. And the last is the clinical effect of neoplasia. So you are warmly welcome as we are proceeding with this important lecture. In introduction, we say the word tumor was used in the past to describe non-neoplastic swelling. For example, if you remember, in acute inflammation, we used to describe tumors as swelling. We know that in inflammation, the cardinal feature of inflammation, one of it is swelling. So you may find with term swelling as tumors. So in the past, the word tumors was used to describe non-neoplastic swelling. But nowadays, we don't use tumor to describe non-neoplastic. We only use the terminology tumor to describe neoplasm. So when we are saying tumor, we mean neoplasm, which are neoplastic swelling and not non-neoplastic swelling. So it's very important to understand that. Cancer, which literally means club, of course you remember, a club which has many legs spreading out. So it was the term which is literally meaning club, because tumor, they have a tendency of metastasizing and spreading out to other structures. So that's why it was known as clubs, or it is equivalent to say club. This is a term which is used mainly for malignant tumors. Don't forget, we said neoplasia can be benign and malignant in introductory part. So for epidemiology purpose, we are saying that cancer is the leading cause of death, the second leading cause of death after cardiovascular. So cardiovascular is number 1, and number 2 is cancer. So I'm saying of cancer, malignance, not benign. So coming to definition of important terms, we say the word neoplasia, this is derived from 2 Greek words. We have neo means new, and we have plasia means things formed. So by that saying, neoplasia means formation of new thing, or it is a formation of new growth. That is neoplasia, or simply new growth. So neoplasia is a process of forming a growth, while neoplasm is the growth itself. For example, this is a cell, it divides into 2 cells, then further into 2 cells. At the end, we can end up with having so many cells. These cells are new formed cells. The process of forming these new cells, which is abnormal, is known as neoplasia, while the mass which is formed is known as neoplasm. So it is very important to differentiate neoplasia and neoplasm. So we say normally the cell in the body do replicate, because neoplasia is a formation of new thing. We form a new thing from cell division as far as the human cell are concerned. So normally the cell do divide. For example, remember during pregnancy, the breast increase, the cell increase. During growth, the cell increase. For example, let us take an example of the thyroid stimulating hormone, which is produced from the anterior pituitary. The hormone from the anterior pituitary, we saw in physiology, they are trophic. They stimulate, they lead to an increase in size and number of cells in their particular glands. So when the gland is stimulated, that is a thyroid gland. When the gland is stimulated by thyroid stimulating hormone, it will increase in size. It will increase in size. So normally the cell do increase. But why do we say neoplasia? Neoplasia also is an increase in cell. But this increase in cell is abnormal increase in cell. It is abnormal increase in cell. Why abnormal? Because it lacks these two things. Number one, it is not coordinated. It is not coordinated, not coordinated. Number two, it continue despite cessation of the stimuli, despite the absence of the stimulus which evoked its division. For example, if the thyroid is replicating due to thyroid stimulating hormone, so when this replication is not controlled, and when the thyroid stimulating hormone is being stopped from being produced, but the thyroid cell continue to replicate, that is abnormal replication. So that's why we say this is neoplasia. Neoplasia, by simple definition, it is abnormal proliferation of cell which is uncoordinated and persist despite cessation of the stimuli which evoked its replication. So it is better to understand that definition. Neoplasia, as I said, abnormal growth of tissue which is uncoordinated and continue despite the cessation of the stimuli which evoked its growth. So it occurs due to genetic mutation. Why genetic mutation? I said normally the cell do divide and the organs do grow. So when we are saying neoplasia, this is abnormal growth. In abnormal growth, meaning there is normal. So we must see how does the normal growth of the tissue occur. Normal growth of the tissue occur due to cell division. Cell divide and become many, increase in number. So when there is a mutation of the genes which control this process of cell division, they will result to excessive growth or excessive division of these cells which is uncoordinated. So let us have a look of the genes which control cell division. Within a cell there is a DNA. There is a nucleus. Within the nucleus there is a chromosome, and within a chromosome we have a DNA, and the DNA have segments. These segments are known as genes. So genes, these are small segments of the DNA responsible for particular traits. So we have the genes which are responsible to control cell division, that is normal cell division. We have three genes which I would like it to pass through. Number one, we have the pro-oncogene. These are genes. When stimulated, they lead to cell division. They initiate cell division. When you stimulate this pro-oncogene, the process of cell division starts. So you will have many cells. So these are pro-oncogene. So why do we call them pro-oncogene? As we have seen that these are cells, these are genes, when stimulated, they lead to cell proliferation. We call them pro-oncogene because mutation in this gene lead to excessive proliferation of the cell, leading to neoplasia. So neoplasia, again, as I said, it is tumor oncogenic. That's why we say pro-oncogene, meaning when we stimulate this gene abnormally, they will lead to excessive proliferation of cell, leading to neoplasia. The second type of genes, the second gene which controls cell division is known as tumor suppressor gene. Tumor tumor suppressor gene. Tumor suppressor gene, these are gene as it sounds, suppressor, meaning to stop. These are gene which when activated, they stop cell division. Remember, in normal cell division, pro-oncogene will be stimulated and the cell will start proliferating or dividing. The cell will start dividing from a single cell to many cells, leading to organic growth. So when the growth or division of the cell is enough, we need to stop this process. So we stop by activating tumor suppressor gene. These are the genes which will suppress or will stop the cell division. The last gene I would like to pass through is the apoptotic gene. Apoptotic gene. Remember from introduction in pathology, we passed through apoptosis. Apoptosis is programmed cell death. Programmed cell death. So these are the genes which, when activated, they lead to programmed cell death. They lead to cell death. These are so important in this circumstance. Just imagine we have a cell which has lost cell control in cell division. So it is dividing abnormally. So when the cell come to realize that it is dividing abnormally. So to stop this division, we need to kill this cell. So these apoptotic gene, when activated, they will result to killing of this cell. Killing of this cell will cancel cell division and will cancel the process of not going into neoplasia. So after passing through those three genes, this tells us that for neoplasia to occur, there must be mutation either in pro-oncogene, meaning that these cells are mutated and proliferating without control and continue despite stopping the stimuli. And the second, tumor suppressor gene are not working, meaning that they cannot even suppress the cell division. And the last, apoptotic gene are not working, meaning that even after realizing that the cell is abnormally replicating, it cannot initiate self-killing of the cell. So when there is a mutation in these three genes, that is where we have neoplasia, which is genetic mutation. As I said, this genetic mutation lead or allow excessive uncontrolled proliferation of the cells. And to insist, neoplasia arises from a single cell. It is a single cell which get mutated, and after being mutated, it proliferates abnormally. It continues to proliferate abnormally. Tumor suppressor gene are not working. Pro-oncogene are highly activated, and the apoptotic gene are also mutated, not working. So because the neoplasia arises from a single cell, meaning that at the end we have a group of many cells which are of the same origin, Therefore, by so saying that neoplasia arises from a single cell of the same origin, that is why we call neoplastic cell clonal. Clonal meaning that they are of the same origin. They resemble each other. They have developed or divided from a single cell. Neoplasia, to classify it, we can classify neoplasia into two groups. We have benign. These are humble neoplasia, meaning that they don't grow fast and they don't spread to distant organ. This is a humble neoplasia. And the second is malignant neoplasia. Malignant, these are very aggressive neoplasia. They grow in very excessive rate, and they can spread to other distant organ. That is malignant. So to summarize, neoplasia are divided into benign, that is humble tumor, and malignant, which is aggressive neoplasia. Okay, let us have a look on how do we name the neoplasia. To understand the naming of neoplasia, we must first know what is the component of this neoplasia. The component of the neoplasia contain two types of cells. Number one, we have the cells which are highly dividing or mutated cells. Number two, we have supporting structures. Supporting structures are not mutated, but they are supporting the highly growing cells. For example, you have a mutation in the thyroid, and the thyroid is highly dividing, leading to thyroid adenoma. So because the thyroid, for the cell to divide, it needs glucose, energy, and other nutrients. So blood supply should increase. So you will have increase in blood vessels supplying the cell. Also, other supporting structures around that organ will increase. And this is the second part of the tumor, which is, second part of the neoplasia, which is supporting tissue. Supporting tissue are not mutated. The mutated part is parenchyma. Parenchyma, this is a part containing the highly dividing cell. So we are naming neoplasia by using parenchyma, which are the mutated cell highly dividing. We don't name parenchyma using supporting structures. So after understanding that, let us have also a look on parenchyma. Parenchyma, as we said, this is a part of highly dividing cell. It can be of mesenchymal origin or epithelial origin. Epithelial origin, these are epithelium which form whole organ. These are organs with empty lumen, such as your GIT. You remember the intestine from the esophagus, stomach, duodenum, small intestine with the large intestine. Of course, this is an example of hollow organ. We also have the trachea. Trachea is hollow organ. The second organs, which are made up of epithelium, these are all glandular tissues. Glandular tissues such as the thyroid gland, adrenal gland, and the pituitary with the other glands are all made up of epithelium. And the last part, we have the covering layer of the structures. For example, the skin. The skin is made up of epithelium. So we can have epithelium, and the example of mesenchymal, these are structures apart from those which I have mentioned. For example, the bone, for example, the bone, connective tissues, bone, structure like chondrocyte or cartilage, they are all made up of mesenchymal. These are connective tissue. So let us proceed. Now let us start to name benign. Let us start to name benign. We have said to name, we must first understand what is the component of the tumor. We said the component of the tumor can be, parenchymal and the supporting structure. Parenchymal are the highly dividing cell, while supporting structure are not dividing. And the dividing part, which is parenchymal, can be either of mesenchymal or epithelial in origin. Epithelial is said this structure having epithelium, and I also mentioned this structure having mesenchymal. So to start, we start naming benign. We say benign are humble tumor. As I said, neoplasia can either benign or be malignant. So benign are humble tumor. Naming of humble tumor, they all end up with the suffix "oma." With the suffix "oma", as I said, with the suffix "oma." So the name of the tumor is incompleted at the end with the suffix "oma." So, for example, when we are naming, for example, when the highly dividing cell or neoplastic cell are fibroblast cell, when they are fibroblast cell and they are benign, so we have to add the "oma" in fibroblast cell. That will be fibroma. So the benign name of fibroblast will be fibroma. Also, we have cell of the cartilage, that is cartilaginous cell. Cartilaginous cell are known as chondrocyte. So because they are benign, so we add the "oma." It is chondroma. So chondroma, These are benign tumor of chondrocyte. So if it is in cell of the smooth muscle, cell of the smooth muscle are known as leiomyocyte. So if they are leiomyocyte and they are benign, so we just add oma, and they will be called leiomyoma. They will be called leiomyoma. Of course, I would like to insist on this. Leiomyoma, it is for smooth muscle, while skeletal muscle are made up of cells which are known as rhabdomyocyte. So when rhabdomyocyte are mutated in a benign fashion, we add oma, they are known as rhabdomyoma. They are known as rhabdomyoma. Of course, students, it's some of you are highly confused, particularly in matching item exams. They give you benign tumor of smooth muscle and a benign tumor of skeletal muscle. In column B, they give you leiomyoma and they give you rhabdomyoma. And you tend to confuse between rhabdomyocyte with thymus and leiomyocyte with skeletal. Again to insist, student, smooth muscle are leiomyoma, while skeletal muscle are rhabdomyoma. So when we have a mutation of smooth muscle, we say it is rhabdomyoma when it is benign, and for skeletal muscle will be rhabdomyoma when it is benign. Of course, this is a picture to show you of a benign growth. That is a picture of a neoplasia, neoplasia which was removed from a patient. Okay, let us have a look of this. Is uterine fibroid. Of course, you can see these are all neoplasia, neoplasia which are benign in the uterus, in the uterus. So they can grow inside the uterus, they can grow within the myometrium. Remember, the uterus have three layers. We have the endometrium, they can grow within the myometrium, and we have the perimetrium. So we can have those outside the uterus. Nomenclature of epithelium. Starting with the nomenclature of epithelium, it's a little bit complex. It is based on cell of origin. Also, we can name it depending on microscopic architecture or microscopic pattern of this cell. So we name based on cell of origin, or we name based on microscopic appearance or microscopic pattern of this cell. So starting with cells which are glandular in nature, meaning gland, or they are not glandular, but microscopically they appear as glands. Remember, we said we name epithelial benign tumor based on cell of origin or microscopic pattern or microscopic appearance of these cells. So when they are glandular in origin, meaning they are glands such as the thyroid, or they are not glandular, but microscopically they look like gland. So if that is the case, we only say it is adenoma. Adenoma. Adeno standing for glands, and the oma standing for benign. So whether they are glandular in origin or they have pattern which are they have microscopic pattern which are glandular like, they are known as adenoma. For example, we can have thyroid adenoma, we can have pituitary adenoma, we can have adrenal adenoma, and others. And those which are non-glandular tissue, such as renal tubule adenoma, these are not glandular, but microscopically they resemble glandular. That's why we name them adenoma, renal tubule adenoma. Okay, Coming to papilloma, of course, these are microscopic or macroscopic finger-like projection from the epithelium surface. If, for example, you are having a neoplasia within the trachea, which is a finger-like projection. They are growing in a finger-like projection, or microscopically they look like a finger-like projection. This is the esophagus, and you have the growth which is finger-like. Let me draw it very properly. For example, this is your esophagus, and this is the lumen of the esophagus. You have a growth which is finger-like. All of these are known as papilloma. They are known as papilloma. So remember, papilloma is a finger-like projection from the epithelial surface. Okay, naming of malignancy. Naming of malignancy, they depend whether the parenchyma part is of mesenchymal origin or is of epithelial origin. When the parenchyma contains mesenchymal tissue, we add the suffix sarcoma. Now, let us have example. For example, when we have fibroblast malignancy, they are known as fibrosarcoma. Remember, when they was benign, it was fibroma, because in benign we add oma, but in malignant we add sarcoma in mesenchymal tissues. When they are chondrocyte, of course chondrocyte are series of cartilage, they will be called chondrosarcoma and not chondroma. Chondroma is a benign, while chondrosarcoma is a malignant. When we have malignant cell of the smooth muscle, they will be known as leiomyosarcoma. Smooth muscle, they have leiomyocyte, so they will be known as leiomyosarcoma. Remember, its benign was known as leiomyoma. When we have malignant tumor of the skeletal muscle, they will be known as rhabdomyosarcoma. Remember, the benign was known as rhabdomyoma, but malignant are rhabdomyosarcoma. Of course, you can just see these are malignant growth, neoplastic growth, which is malignant in this patient. Okay, we are continuing in epithelial origin. In epithelial origin again, when they in epithelial origin, generally we say they end up with a suffix carcinoma. Remember, we said in mesenchymal origin, they end up with a suffix sarcoma, but in epithelial origin, they end up with a suffix carcinoma. So don't forget that. Now let us start to name. When they are glandular structure or microscopically they look like gland, they will be named as adenocarcinoma. Remember, the benign part was known as adenoma because we are adding the suffix oma. We were adding the suffix oma. That's why we called them adenoma. But in a malignant, we call them carcinoma. So they are adenocarcinoma. When we are having malignancy of covering layers of the body, such as the skin, or covering layers of the whole organ, we will be naming them as squamous cell carcinoma, because the epithelium of the covering layers of the body structure are squamous cells, so we have squamous cell carcinoma. When the malignant are macroscopically visible as projection that arise from mucosal surface in the lumen, whether they are benign or malignant, we name them as polyp or polypoid. We name them as polyp. So this is just an example of polyp. This is microscopic appearance. Okay, we can have mixed tumor. These are tumors which are composed of both epithelium and the connective tissue. Remember, connective, we said the tumor has a parenchymal part, which are highly dividing cell and have connective structure. So we can have mixed tumor, both of epithelium, which is a highly dividing cell, and the connective tissue. Example of this tissue are such as the salivary gland. The salivary gland neoplasia are pleomorphic adenoma. So we call them pleomorphic because they are mixed. They have mixed cells. So we call them pleomorphic adenoma. Again, adenoma because the salivary is a gland. We can also have teratoma. Teratoma, these are neoplastic cells arising from germ cell. Of course, germ cell, remember, these are the reproductive, of course, germ cell of reproductive cell. For example, the sperm and the ovum. So, tumor arising from the sperm cell or ovum, they are known as teratoma. For example, cystic, ovarian cystic teratoma. Ovarian cystic teratoma. Okay, let us have a special nomenclature. Special nomenclature means these are malignant tumor which have names sounding like benign. These are malignant tumor which have names sounding like benign. For example, we can have malignant tumor of lymphocyte. Malignant tumor of lymphocyte, they are known as lymphoma. So you can just see at the end we have the suffix oma. The suffix oma was supposed to be in benign, but now we find it in malignant cells, but they sound like benign. This is special nomenclature. We have mesothelioma, of course, particularly in the cell of around the lungs. We have melanoma. Of course, melanoma, these are melanocytes secreting melanin, which is responsible for darkening of the skin. So it sounds like benign, but it's malignant. We can also seminoma. For the same, we can also have glioma or osteoma. Of course, these are the cells within the central nervous system. We can also have hepatoma. Hepatoma, of course, the cells of the liver, hepatocyte. Okay, coming to blastoma. Blastoma, these are tumors arising from immature cells. Of course, remember when the cell is dividing, it starts from a single cell. This single cell is immature. As the cell proceeds with division, it mature and differentiate. So meaning malignant cell arising from immature cells, which are not mature, immature, not well developed, not well matured. All of these are known as blastoma. They are known as blastoma. For example, when we have immature cell of the nervous system, of course we will have, for example, medulloblastoma. When we have malignant of immature cell of the retina, that is retinoblastoma. When we have malignant cell of immature in the nephron, that is nephroblastoma. So that is blastoma. Blastoma is the naming for benign tumor which are of immature or composing immature cells. Coming to special naming, we are continuing. Coming to non-tumors which sound like tumor. These are non-tumor growths, but they sound like tumor. We have hematoma, a focal growth that resembles a neoplasm, but results from fault development of an organ. It is a fault development of an organ which is not malignant, but it sounds like a neoplasia. For example, chondroma of the lung or adenoma of the liver. We can also have cholestoma. These are heterotropic rest of cells, a mass of histological normal tissue found in the abnormal location. For example, mass of the pancreatic cell found in submucosal of the stomach or duodenum, such as ectopic rest of normal tissue, the rest of adrenal gland under the kidney capsule, or rest of bladder gland in the jejunum and the ileum. To summarize on nomenclature, let us have a look on this diagram. It has 3 columns. The first column has a tissue of origin. The second column is whether the neoplasia is of benign type, and the third column is whether the neoplasia of a malignant type. So in tissue of origin, whether it is mesenchymal in origin or connective tissue and its derivative. For example, fibroblast cell. When they are fibroblast cell, its benign will be fibroma. Remember, we said all benign, they end up with the suffix -oma, and all malignant, they end up with the suffix sarcoma. So if it is a fibroblast, it will be fibroma, and its malignant will be fibrosarcoma. When it is a lipocyte, it will be lipoma, and its malignant will be liposarcoma. When it is a chondrocyte, of course, chondrocyte are series of cartilage, it will be chondroma in a benign, in malignant will be chondrosarcoma. When they are series of the bone, osteocyte, in benign will be osteoma, while in malignant it will be osteosarcoma. There will be osteosarcoma. Okay, endothelium structure. When the endothelium and related tissue, such as blood vessel, lymph vessel, synovium, mesothelioma, and the brain covering. Okay, they will be named like this. In a blood vessel, we will say if it's benign, will be hemangioma, ending with the suffix -oma. In malignant, will be angiosarcoma. In lymphatic vessel, we'll have lymphangioma. In benign, in malignant, we'll have lymphangiosarcoma. While in synovium, we'll have synovioma and synoviosarcoma. Remember, mesothelium doesn't have benign, so they only have malignant. We said these are malignant which have nomenclature resembling benign. These are mesothelioma. While covering of the brain, such as meninges, in benign they will be named as meningioma, while in malignant they will be named as meningiosarcoma or invasive meningioma. To continue with your naming, when the tissue of origin is hematopoietic cells or lymphoid tissue, we don't have benign in hematopoietic and lymphoid tissue. In this category, all neoplasia arising from hematopoietic and lymphoid tissue are malignant. They are not benign. So if they are hematopoietic cells, of course, these are cells of blood cells. These are known as leukemia. When we have neoplasia in cell of lymphoid tissue origin, they are known as lymphoma. Of course, we shall discuss them in leukemia and lymphoma chapter. Okay, when we have smooth muscle, as I said, they are leiomyoma because they have leiomyocyte cell. That is, if they are benign, and when they are malignant, they are leiomyosarcoma. In skeletal muscle, we have rhabdomyocyte, so we have rhabdomyoma, and in malignant, we have rhabdomyosarcoma. In epithelium tumor, of course, we have squamous cell carcinoma and or papilloma if they are finger-like projection, and we have carcinoma if they are malignant. We have adenoma if they are glandular origin, and we have adenocarcinoma if they are malignant. We have papilloma again and cystadenoma. That is benign. Of course, we don't have malignancy of this type. Of course, in the nervous system, if they are from the neurorectoderm, we have nervous, and if they are from the renal tube, we have renal tubular adenoma and renal tubular carcinoma. If they are from the liver, we have liver cell adenoma, sometimes hepatoma, and hepatocellular carcinoma. We have transitional cell papilloma and the transitional cell carcinoma if they originate from the epithelium of the urinary tract. If they are from the placenta, the benign is a hydatidform mole, and the malignant is choriocarcinoma. If they originate from the germ cell, we said they are seminoma. If they originate from the testicular germ cell, it is known as seminoma. Okay, when they have more than one neoplastic cell type, that is, we have matured teratoma and immatured teratoma. Okay, coming to characteristic of benign and malignant. In characteristic which differentiate between benign and malignant, we use the following criteria to differentiate them. We differentiate them based on morphology, differentiation pattern or degree of differentiation, and morphologically appearance, microscopic appearance of these cells, whether they are well differentiated or poorly differentiated. We also differentiate them by using rate of growth. As I said, benign are humble tumor, so they grow very slow. So we say, as far as the rate of growth is concerned, benign grow slow, while malignant grow fast. Local invasive. Remember, benign are very humble, they don't invade the local structure. So in benign, we say there is no local invasion, while the malignant tumor, they tend to invade the local structures. Metastasis, this is a spread to distant structures or distant organ. Benign, again, don't spread, and malignant do spread. Okay, to insist on differentiation pattern, remember, the cell, when they are starting to divide, they start from a single cell which is highly immature. When the cell is highly mature, it will be dividing very fast. So all malignant cells are having cells which are highly immature. And because these cells are highly mature, you cannot differentiate them clearly. You cannot clearly say this is a cell which looks like the thyroid cell. This is a cell which looks like the osteocyte cell, or this is a cell which looks like a chondrocyte cell. They are poorly differentiated. You cannot clearly say this is a cell of a particular organ. So malignant, because they are immature cell, they are poorly differentiated. While the benign are mature cell, since they are mature cell, we can easily determine or say these are cells of a particular organ. Okay, I will have to pass through this diagram to which differentiate benign and malignant. I said we have the criteria to use. This is column number 1 having characteristic, and we have column number 2 having benign, and we have column number 3 having malignancy. As far as characteristic is concerned, depending on differentiation, we say benign are well differentiated. We can clearly say these are the cells of a particular organ. Why? Because they are mature cells. While malignant are immature cell, we cannot differentiate it. We cannot easily differentiate them. We say they are poorly differentiated. Rate of growth, we say the benign, they grow very slowly, while the malignant, they grow very fast. Local invasive, benign do not invade the local structure, while the malignant invade the local structure. And the metastasis, we say benign do not metastasize, while the malignant, they metastasize to distant organ. Of course, this is a diagrammatic comparison. This is a benign. You can see well confined, has not invaded the local structure. This is malignant. It has started to invade the local structure. So you can see that is the diagrammatic differentiation of benign and malignant. Okay, mode of spread. Mode of spread of tumors. The tumors can spread in 3 modalities. They can have direct seeding. Direct seeding is, for example, we have the organ here. This is the organ which has a neoplastic cell, and this is another organ which is very close to this organ which has a neoplastic cell. So this neoplastic cell, they tend to spread direct to this nearby organ. This is direct seeding. Okay, another way of spreading is through lymphatic drainage. So this is organ here, and this is another organ here. This organ here has a neoplastic cell, and because there is lymphatic drainage, so you find that these cells which are mutated, they spread through the lymphatic channel from this organ. These are the cells, cancerous cell. They spread from mutated organs or neoplastic organs to the organ which has no mutation. You found that this organ also have the cell which are mutated because they have spread through the lymphatic system. This is what we say lymphatic spread. And the last is the hematogenous spread. Of course, you can have, this is again organ which is mutated, you have mutated cells, and we have the organ here which is not mutated, and this is a blood vessel. For example, assume this is a GIT, your GIT, any neoplasia in the GIT, and this is the liver. Remember, drainage from the GIT passes through the liver. So you found these mutated cells, they travel from the GIT up to the liver. So that is hematogenous spread. Hematogenous spread, it is a spread through blood vessel. We said there is 3 modalities through which spread can occur. Direct seeding, that is the cell they go to nearby structure directly, or through lymphatic drainage, that is the second way, and the last is through hematogenous, that is through blood vessels. Of course, I'm skipping this slide because I have already explained them. Okay. Mechanism of tumor metastasis. The tumor started to invade extracellular matrix of the nearby structure in direct seeding, and in vascular dissemination, that's where the tumors travel through vessels. The vessels can either be lymphatic, that is lymphatic spread, or can be blood vessel, that is hematogenous spread. Thank you. That marks the end of our discussion. Of course, I tried as much, so you can take your time to review these videos as much as you can so that you can understand. And to insist after this, please go to literature books to pass through.